We have our star speaker, Dr. Steve Mansberger, who is has come all the way from United States of America. He is the chair and director of the glaucoma services at the DUS Eye Institute, Portland, Oregon. And it's a pleasure that he is with us, and he'll be sharing experience with something which is going to come soon to India, the minimally invasive glaucoma procedures, what's known and what's missing. Stephen, please.
Thank you very much. It's been my pleasure to be here. I first want to ask the audience, who in this audience has used a MIGS? Can you just raise your hand? So we've got about 4 people. Okay. So these are my conflicts of interest, and some of these are related to MIGS, but the biggest conflict of interest is the last one there. And I consider myself a middle adopter of technology. So I waited about 2 or 3 years to get my first iPhone, and then I got it. I wanted everybody else to figure out all the kinks and things, and then I was going to get my iPhone. And so same thing with me with the minimally invasive glaucoma procedures. I will let other people try these out, and then I'll eventually jump in. But I'm experienced in eye stent, endocyclophotocoagulation, canuloplasty, goniotomy, and I do a lot of cataract surgery as well. So this is George Spaeth, and one of his statements is innovation is an integral part of medical care. So we're always trying to improve our care. And for glaucoma surgery, we want to have less risks, we want to have more benefits, and we want to have less costs. And so we're always trying to improve our therapy to do that. So this is a very busy slide, but I want to kind of show the audience how busy and how complicated MIGS surgery are in the United States. So what we have here on the right side is we have traditional glaucoma surgery. This would be your typical Barveld and Ahmed implants, your trabeculectomy, and what we have on the left side is all of the minimally invasive glaucoma surgeries that are currently being investigated. There's ECP, endoscopic cyclophotocoagulation, which has been around for about 20 years. We've got multiple different implants. We've got ways of cleaving or removing parts of the trabecular meshwork. Dr. Ung was talking about some of these injections which might get the trabecular meshwork to work better. We have ways of dilating the canal, Schlemm's canal, to improve, and then there's implants that are also being tried. So one of the messages about this, when you see a slide like this and you see all these different therapies, one of the things you'll really realize is that there's probably not one that's winning out. And that's what we're finding out, is that some of these treatments have benefits in some people and some in not. So this is one of my clinic days. I have a 65-year-old radiologist who's got a history of herpes zoster, pigmentary glaucoma, steroid response. He has a scleral buckle for retinal detachment, and he hasn't had a laser. And his pressure is 36, and his vision's 20/25 with a 3 diopter myopic shift from a cataract. And we're asking ourselves, do we want to do a standard glaucoma surgery on this guy, or do we want to do something else? I have a 58-year-old IT programmer who has got glaucoma. He's intolerant to almost all of the eye drops. He's at SLT twice. His pressure is 22, his target's 14, and let me see if I can go back here. And anyway, let's see if I can go back. Can you go back a couple slides? I'm just trying to. Anyway, he's trying to decide whether or not he wants to have a traditional glaucoma surgery. Both of these patients said they didn't want a traditional glaucoma surgery. So this is one option for them is just standard cataract surgery. And this is a paper we published several years ago looking at ocular hypertension patients. And you can see a large drop in pressure over time with cataract surgery, and the pressure stays low for a long time. So one of the messages about this is cataract is pretty forgiving. It improves their vision, and it also lowers pressure over a long period of time. And this is the typical change with just cataract surgery. You get somewhere about 70% of patients will have at least a 10% drop, and about 40% of patients will have a 20 to 30% drop in pressure with just cataract surgery alone. And we know patients that have narrow angles will even get more lowering in pressure with cataract surgery alone. So cataract surgery is probably one of the most easiest and one of the best ways of doing a minimally invasive glaucoma surgery, but it's not on that list. And this is just a snapshot of all the different minimally invasive glaucoma procedures. This one on the right, you can see here, that's the ECP, and we saw the micropulse lecture just a little bit ago, and this is just treating the ciliary body from within. We got viscocannulostomy down here. We have a gold Solex shunt that was placed in the suprachoroidal space. We have the eye stent. We've got a shunt that goes in the suprachoroidal space. We got the trabectome. We've got the GAT procedure, which is a gonioscopy-assisted transluminal trabeculotomy. So we've got so many procedures that we're trying. So what are the expected outcomes? If we remember conventional outflow, this is a study that was done by one of our fellows way back when, named Rosenquist. And what he did was he looked at when you removed anywhere from 1 clock hour to 12 clock hours of the trabecular meshwork and how much increased or decrease in flow you would get. And what he showed was you can only eliminate approximately about 40 to 60% of the trabecular meshwork outflow, even when you remove the whole trabecular meshwork. So even if we do these MIGS procedures through the conventional outflow pathway, we're only going to remove about 40 to 60% of the outflow resistance. And that another consideration is episcleral venous pressure. This is the Goldman equation that averages between 8 and 12 millimeters. And so if you're going to, if you need a low target pressure, that with the going through the conventional outflow pathway, the lowest you can get is 8 to 12 millimeters of mercury. So again, if you need low pressure, then you probably don't want to do one of these minimally invasive glaucoma procedures. So this is one of the seminal papers looking at the eye stent. And what you can see is cataract with the stent here in this column, cataract alone in this column. And you can see that the pressure lowering is really very similar, about a 30% drop in the cataract alone and a 33% drop in the eye stent. And the medications after 2 years was very, very similar. So the reason this was approved in the United States was really not based on efficacy, it was based on safety, that this was very safe. So, but there were some patients that had got a really nice response. This is another minimally invasive glaucoma procedure. This is placed in the suprachoroidal space. There's a little picture of this in the corner. And you just place this just underneath scleral spur, so it slips into the suprachoroidal space. And what you can see here on this slide is those at low pressures, there was very little difference when this was placed in the suprachoroidal space except for those that had higher pressures. Higher pressures had a larger response with the suprachoroidal shunt. And then this is another study looking at the trabectome. This is a device that removes the trabecular meshwork for about 2 clock hours and about 20% success, which doesn't sound great. But about 20% of those didn't require any further surgery. So even though it was only successful in 20%, it did work with them and kept their pressure low. And then what about cost? These devices are very expensive. The eye stent costs about $2,000 for this stent. Most of them average between $1,600 and $2,400 for US dollars for the cost. And so it's going to be interesting to see down the future if they've got just a small benefit in decreasing medicines and decreasing IOP, whether the US government is going to continue to pay for these. So when is our consideration for MIGS? Early disease is probably a good candidate. A target in the high teens, so somebody with a very high pressure just needs to get in the teens. When it's and able to use medications, because most of these patients need to use medications, and whether they're willing to have another eye surgery in the future. I want to remind everybody, this is a paper published in 1998, so if I'm doing my math here, over 20 years ago. And this was a summary of all the different glaucoma implants that have been done since 1907. And what you notice here is many of these implants that we currently are trying and have been tried before. So right down here we see a hydrogel stent, which is very, very similar to the Zen stent. That was tried in 1995. And it just didn't work. Nowadays we have mitomycin C, so maybe this would work. There's other different limbal stents. There's been cyclodialysis stents that have been tried. This was done in 1952. So we've tried these stents again, and so it's just going to be interesting to see whether just recapitulating history or whether these will be found to be beneficial. So the ideal glaucoma surgery only requires 4 things: continuous IOP sensor, titrable adjustment of intraocular pressure. So just like a pacemaker, you could just turn your pacemaker. You can say you want your blood pressure at 80. So just do that. Outflow pathway of the eye and a short learning curve. This is just a video of, let's see if it'll play here. This is a video of a non-human primate with a intraocular pressure sensor from Crawford Downs, who was at our institution. And what you can see is the ability to check pressure. This is 100 times or 500 times per second, and you can see this large variability in pressure. But we just need this device with a pumping mechanism, and we've got now the perfect minimally invasive glaucoma procedure. So what happened to these 2 patients? The 65-year-old radiologist, I told him, you might need a conventional glaucoma surgery, but let's just, and he said, but let's just try cataract alone. That's your major symptom. And he had cataract surgery alone, and his pressure came down to 18 with no further medications, and I've been following him now about 2 years. So he's done really, really well with this. And actually, we added latanoprost, and his pressure now is like 14. The 58-year-old IT programmer had a trabeculotomy. His pressure is 18 on 1 drop alone. He does complain that he gets bleeding inside the eye periodically when he puts his head below his heart, but he's been happy as well. So in summary, cataract surgery lowers pressure in most patients. MIGS surgeries using conventional outflow have IOPs in the high teens. Our unmet need is we don't understand which devices work in which person. Right now, it's just the surgeon who's comfortable on this device, that's what he does. And so I think soon we'll have a titratable, pressure-sensitive surgery in the future. Thank you.
Thank you, Steve. That was a very fascinating lecture.